Rich, give us some pearls on pediatric resuscitation.
The key pearl is to not go to work that day. Let's be straight about this. I've been practicing far too long. I just came back from sabbatical. I had a 6-month sabbatical to do a project. The net result was I didn't do the project, and my wife made me go back to work. She kept calling the hospital administrator saying, he doesn't need 6 months. He needs about 4 days. This is a wonderful meeting. I've been in and out of it for years. The people who set it up are motivated. Michael called me. He said, I want you to talk about dead kids. I said, oh, come on. It's 4 o'clock. I said, I can't do this. What can I help you with? But there's a lot to talk about. I'm going to give 3 talks, one on resuscitation. Tomorrow we're going to do crashing scary babies, as well as some breathing troubles. How many of you take care of adults? It's a joke. So I'm supposed to find out the caliber of the intellect of my audience, and right away you've already declared yourselves crazy for taking care of adults, because why would you ever want to take care of an adult? They don't get better. Well, besides this talk, most kids do quite well. So with that in mind, let's just plow through this. The objective slide here, I'm going to show you some general management tips. And Michael was right. There's some stuff I've learned over the years from codes and things that matter. I'm going to show you quickie stuff on the changes and recommendations with BLS and ALS. And I'm going to talk a little bit about bradycardia. I want to focus on some Brady issues as well as tachy issues. And I think you've all seen some of this stuff. And then in the end, some pitfalls. So with that in mind, let's just get to management principles of saving a life. The first one is and I'm going to go back a bit. You got to get an IV in somebody. We don't give endotracheal meds anymore. You shouldn't. And everybody forgets the basics, and I put up some fancy clip art for you. Hands and feet are always there. And with today's sonography, this is going to be an obsolete slide. You're going to have much better access for these kind of sites. But I love the scalp. How many of you have ever put a scalp vein in somebody? Come on, it's not an AA meeting. Let's go. Have you? Okay. It's incredibly gratifying because nothing is going on up here in an arrest or an acute resuscitation episode. And you can really see, if you take a look how expensive, I think he told me, let's see. Yeah, I love this thing. How expensive is this piece of equipment? The rubber band and tape. They don't even have a drug rep at a meeting. Anyway, it works. My little pitch. The second thing is, everywhere you work, and I'm sure everybody's worried about having enough McGills and forceps and glide scopes and CMAX. I mean, how many of you have umbilical catheter trays in your hospital that you can get? Get one, because when babies are under 14 days of age, you can use the umbilicus as a site for cannulation. And it is, let me get a better picture. It is extraordinary in terms of how accepting it is of a catheter. Let me see if this does work here. Okay. You slice it, and at 14 days, it stands at attention. Has anybody done this in an emergency department? Have you enjoyed it? That's a really weird way to put it. Have you had good success with it? Yeah. I just wanted to put it in there. But in the end, we have evolved, and I'll move through it, to something a little more eclectic, and that's the IO needle, okay? Now, obviously, how many of you have put an IO in any age group patient? Okay, good. Everybody does this. IOs used to be experimental. IOs used to be never done on conscious people. Now we use them as immediate therapy, even for an awake, alert, dehydrated, very obese baby. I used to think it was, like if I did it on a child who was dehydrated and had no access, but was awake and alert, I was committing a sin against nature. But I'd rather get a quick IO in, especially with some pain meds, than stick a kid 15 times. I mean, there was an old joke when I trained that if you sent 10 pediatricians in a room with an acute kid who was in dire straits, you would have 9 of them slapping the hand trying to start an IV, and 1 would take care of the airway. Well, that's over now. The IO is the go-to. Now, I'm preaching obviously to the choir here. Basically, almost anything can go in an IO. What is the one drug that can't go in an IO? Adenosine. I know it's a picky answer, but it can't go because of the obvious transport reasons and the degradation of the drug before it gets centrally located. But almost anything else can go in an IO, and it's very gratifying. Anybody here work in pre-hospital care? God bless you. It's saved many kids and many people in-house. And I don't advertise. There's no way any drug company would use me as a spokesperson. Trust me. So I forgot the disclosure slide. You know, I have to add things to disclosure. It says no disclosures, and now in this era I have no obstruction and no collusion. So I'm off the grid. That's it. No more politics. Sorry. No, somewhere out there, somebody's pissed already. Anyway, there's many. I'm not going to do an advertisement on IVs and IO products. I would tell you this is a good product. I don't care. I don't get any money for it. Have something readily available. Okay. Airway intubation is earlier, the better. Tell me if this doesn't ring a bell. The majority of the times you've intubated, you probably should have done it 5 to 10 minutes earlier. And in kids, because you don't have the sea legs, because you don't do kids all the time, it's 15 to a half hour. I am telling you, intubation is a positive therapeutic step. Now, I kick my residents' butts to teach them how to do BLS and bag valve mask, and God bless, you got to know that. But intubation is indicated in almost any critical scenario in a child. I used to do adults. I'm grandfathered in to do adults. I dropped that board because how much money can you spend? But the reality is, the only thing I learned from intubating adults is that the primary indication to intubating an adult is to shut them up. It's unbelievable. I find it so empowering now when I get a belligerent adolescent who comes in, I go, tube them. Everybody's happy. I don't have to deal with them. The resident gets a procedure and it's a level 5 visit. So everybody, I don't see a downside to it. And the PICU guys, you know, why not? But babies, number 2, I'm going to show this slide a lot. Don't be a wuss. Don't say, oh, it's a cute little baby. I'm only going to give him some Versed and maybe Enfamilk. No, their tongues are big. Their secretions are thick. Trust me. Don't be a wuss. Take them out. No, take them out. Use whatever you want to use. Sucks, one of the oniums. I don't care what you use. But some people in peds don't like sucks very much. But you'll figure it out. But don't back down. I'm telling you, if I see one more idiot take a 4-month-old who's dying and say, oh, we'll give him a little Versed and fentanyl. I mean, he's not having a colonoscopy. Tube him. Christ. I'm not going to bore you with why the peds airway is different than the adult. I think you have moved past this slide. All right, I am going to harp on this. When you beg in the field or a kid cries, they distend their abdomen and they fill with air. And if you don't get this out, you can ventilate till the cows come home because they have no vital capacity. And Haney talked about functional residual capacity. It's my favorite measurement. You got to put an OG or an NG in these kids. And usually the smartest person in the room, who is the nurse, will put this in and save your tush. Parents, look at these x-rays. It's my new technique. Man, this is very cool. If they point at that and they say what that is, you say that's the cold. If a child has a cold and you get a chest film, you say that's where the cold is. We've locally. I've started to come up with distractors like that. Like if parents ask me why kids get a slight fever from immunizations, I tell them it's the heat of autism. It's a battle. It's just. I told that joke in San Francisco 2 weeks ago. I did a favor and went out and spoke at a meeting. Crickets. 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 You got to know your audience. I'm in Baltimore. And when I walked in, Haney apologized for the needles on the floor. He told me. So I'm okay with that. I can't emphasize this enough. I always forget this. This is a big deal in babies. They don't have a lot to work with. So don't be shy about that. All right, other pitfalls. Sugar. I do a lot of mistakes talk for ASAP, and my favorite talk is somebody screwed up and didn't get a chem strip. In my mind, any sick child, not just resuscitated child, the ABCs should end with D, and not disability or whatever. D for Dexter stick. Please, just get a chem strip. There's 100 reasons why kids under stress don't mobilize their sugar. They don't have any. Their glycogen stores are lacking, and you're going to blow it. Trust me. And how hard is it to get a finger stick, especially in an acute scenario like we're going to talk about? Excuse me. I'm so committed to this that in Syracuse, I just got a new ER. Over the door jamb, we have a nice sign that says chem strip with a question mark. Every room. Don't be the person who misses that. Number 2, watch the body temp. I think everybody knows that. Babies lose heat very quickly. And number 3, I am telling you, if I had $1 for everybody at the bedside bagging a kid, just staring at the monitor, all they look is SATs, right? And expired CO2. And everybody watches the numbers go down. Nobody listens to the kid, trust me. It's seductive. Electronics is seductive. We are criticizing cell phone use and all the electronic disarray. We're a little bit guilty as well. One day, when everybody's watching the monitor with the numbers, I'm just going to steal the kid and see if anybody notices it. It's a pet peeve. If something is going south that was north, it's the freaking airway. And the airway can be replaced. Pull it out and bag them. This is a big message too, because there's no humility in this. It's not like the relationship where you tell somebody too early you love them. You can't take it back. Pull the tube. Do another one. Okay. Components of high quality CPR. The rate, bless you, the rate of compressions is a big deal. I'm not teaching you BLS, I won't do that. The depth is a big deal. You gotta read the new guidelines. And you gotta let full chest recoil show up between the compressions. And then minimize the interruptions. If you look at the American Heart Association 2015, which we'll go through, you'll see how this all falls into place. Basic life support and CPR equality. Here's the key issues in 15 that changed. Number 1, it's CAB, circulation, airway, breathing as a sequence. I think everybody knows that. There are new algorithms which incorporate the use of cell phones. How many of you are finding cell phone use in the hospital very distracting? Anybody work with med students?
How about nurses? Doctors?
Oh, no, everybody, I get that. Well, when I was in San Francisco, I was walking around looking for one of the marijuana stores, and they well, it's a choice. Jewish museum, marijuana store. What are you going to? I've been to the Jewish museum. And I saw this guy just, texting or walking, and he walked into a pole. I loved it. But cell phones are incorporated now into the world of CPR. And then the 6 compressions, 6 CMs. This isn't what I want to dwell on. And then the rate. Kids have magic heart rates. They live in the hundreds, so you have to match it for the most part. But let's move on to the scary kind of kids, okay? Changes to ALS resuscitation. How many of you remember giving atropine in a code to a child? Of course you do, okay? The concept was when you intubate a kid, they're so vaguely sensitive, they Brady down and you got to do something about it. And, if there's anything we're slaves to in medicine, if there's a drug that reverses a bad thing, we're pulling it right away. And the real therapy for bradycardia when you intubate somebody is to get the tube in. But atropine was first on the list. Everybody knew it. But now, and everything I'm showing you here is level 1 to 3 evidence from the American Heart Association. Atropine is no longer used in peds intubations. This is a big deal because a lot of people just memorize this. And basically, there was also a minimum atropine dose that everybody argued about, which is no longer in use either. So we just don't routinely use it. And we'll talk about bradycardia in depth in a little bit. The second thing is, what antiarrhythmic meds can you use for pulseless or unstable VTAC? You can use amiodarone or lidocaine. And if you look at the literature, and don't get crazy, you'll get a headache, they're pretty equally bad and good. I mean, I don't have any real science to tell you here, but this is the recommendation of the AHA. Vasopressors are, if I was going to buy stock in a drug, it would be epinephrine. You'll see it comes up in almost every discussion point in resuscitation of children, for the most part. And although the studies aren't really solid, epinephrine is completely an approved drug. And then prognostic factors. I gave a talk on the death of a child in the emergency department. It was one of the most important things I've ever done. Nobody knows how long before you call a code. I'm not going to digress into this. But you have a mindset of your own. And now with sonography, where you can see cardiac activity or the lack of it, you've got a little firmer data. But I hate to tell you, the literature hasn't really caught up with that yet. You'll have to make your own calls. But I might as well get the bad news out of the way first, that asystole in a child has almost no survival rate. If a child arrives in the emergency department in asystole, they're pretty well gone, because it takes a long time for a child to get asystolic. What I want to focus on today is the bradycardic or respiratory distress kid that you can make a difference with. And then fluids and inotropes, I'm not going to insult you. People do better when they have a blood pressure. All right, that's the algorithm that you know. That's the overview. But let's take it in real terms. Compressions, like I said, intubation, access with the IO. And generally, those three things happen before they come to your facility with the ALS providers that we have. Defibrillation if necessary, and then epinephrine and that. And it's pretty much that. There's no secrets here. Bicarb isn't in the mix anymore. Bicarb is sort of way down the algorithm. It doesn't really save lives. That's asystole. I wish I tried to glean more for you, but it comes down to airway, breathing, circulation, and again, the prognosis could be sort of mixed. I want to focus on bradycardia now, because this is what you're going to see, okay? Here's an algorithm, the basics. It says, I put an arrow in here. Obviously, ABCs, put people on monitors, get a line. And the number one cause, this is key point number 7, of bradycardia is hypoxemia. This is such a potent predictor that if you look at neonatal, newborn resuscitations in the delivery room, the heart rate determines the intubation and the compressions. It's amazing how sensitive kids are to hypoxemia. If we got hypoxic, we'd be tachycardic, like a pulmonary embolism or the usual adult craziness. Not in kids. I am telling you, if they're bradycardic, and you'll see a difference in a second, it's always hypoxemia. Number 2, you got to get over the fact that they need compressions. Just as much as I told you they live in the 100 to 150 range, they don't like 60. They don't dig it. They want, and you usually have CPR. The beautiful thing is, if you do some compressions on a kid who's on the border of not needing them, they get pissed off and their heart rate goes up. So keep that in mind, sorry. And then in the end, if that's not working, you do have pharmacy, atropine and epi. I'm going to do a case now to make this a little clearer, okay? You probably won't see much resuscitation room bradycardia. I want to show you a case, and this is pertinent to the millennium, okay? We get a case history here of a 2-year-old who accidentally gets into grandpa's heart medications. I am terrified of grandparents. Grandparents are wonderful. They're in all the commercials on television. The commercials on network television between 5 and 7 p.m., when normal people are out, are targeting people from 50 to 80. And what do those commercials show? I call them the hard and soft commercials. Like, there's the soft bone commercial where people take Boniva or they take a calcium supplement. Hardening of the arteries, where they take a Lipitor, or the soft ones with Viagra. But basically, those are the ones you watch. And those are the ones, you know you're in trouble with those commercials because the effects of the drug are about 8 things, and then the side effects, the guy's an auctioneer on the bottom. You know, beware of seizures, apnea, coma, death, and whatever. But heart medications are in homes. How many of you, for example, right now in your own personal home, have baby aspirin in your house? All right, that's it? Some of you should get more. How many of you have, I can't even do this anymore. How many of you have an opiate in your house from a dentist? That's how you know you went to a dentist, because who in the world used to write for T3s and T4s? It's my favorite. But dentists have the highest suicide rate, you know that. But they deserve to die. But back to the heart medications. In Tox world, that's my other hat, we are terrified of grandparents. I gave a lecture at ASAP, and I mentioned that grandparents are dangerous, and I actually got hate mail from the AARP, which I am totally a member of now, so I'll leave it out. They found verapamil next to the kid. This could change to Toprol, okay? I'm just telling you, this is coming your way. And I want to show you, this is much more important than the little kid with bradycardia who needs oxygen. This is a bad case. All right, he comes in and things are unacceptable in real terms. He is, I love this thing, he is bradycardic, and his blood pressure is not acceptable. He's breathing, he's somnolent, and his cap refill is good, okay? Calcium channel blocker overdose. You know what it is. It's pre-announced when the kid comes in. What are you going to do? You got to do something, right? The pharmacologic effects, myocardial, nothing good here. They depress, they vasodilate, they become brady, and they drop their pressure. Kids are heart rate dependent for their pressure, and they go into block later. These kids will die in front of you if you don't make certain steps. This is bad stuff. The therapy, number one, gastrointestinal decontamination. But wait a minute, I just told you bradycardia is bad. And how am I going to decontaminate little Joey if it's within an hour? Is a 2-year-old going to volitionally take charcoal? Only if he's decorticate. No, that's not going to happen. Am I going to load him with Go Lightly with an NG tube? No. So the answer is forget it. It's not going to happen in the young accidental. Now remember, I'm not talking about the adolescent who's upset and takes polypharmacy late in the day. I mean, we're all living through the psych epidemic, I assume. Is that fair? Okay. I hope you are, because I don't want to suffer alone. In peds, we are deluged with psych patients. It's really sad. Most of them are ODD kids and whatever. I would, unlike current administration, I'd like to build a wall for psych. I would just like to keep the psych patients out of my ED. But I'm talking about the 2-3-year-old who gets into the mishap. So you get a line, pick your admission. Okay, what drug can I use for this bradycardia? What's your first line drug? What do you want to give them? Probably no wrong answer. Insulin. Okay. When you go on a first date, do you immediately break up just to get it over with? I used to do that, actually. Atropine. Oh my God, I just told you to never use it. Well, this is where you do use it. And it works, but it wears off. And it doesn't work in calcium or beta blocker overdose. Calcium chloride, why not? I blocked it, give more. It works. Not as well as you think, and eventually it's short-lived. We're making it down here. And then catecholamines. All right, I'm going to hit you. I'm going to get the beta-1. Next line of therapy, try it, epi, norepi, pick something. It will stop working, which leads us to the 2 end-of-date issues. What else can we try? This is one of my favorite slides in the world because it's showing you sneaky ways to stimulate the cardiac cell with glucagon and insulin receptors. And I wish I had $1 for every board question there was where glucagon was the antidote for beta blocker or calcium channel overdose. And basically, it's a miracle drug. And you should stock it and give it. And sometimes with these kids, you need to put people on a glucagon drip, which you don't want to get into, but you might want to check in your hospital to see if they have a lot of glucagon. So glucagon, and that leads me to that correct answer, insulin and glucose. And this has revolutionized beta blocker and calcium channel management. Basically, the target here is insulinize them and give them enough sugar to maintain euglycemia. And it's completely inotropically positive, the high-dose insulin. And there's some other things about carbohydrate utilization. I don't want to bore you with tox factoids. But this is totally indicated and worthwhile. And I put some dosing in here. This will be available on the website. But the case resolution here is his heart rate dropped. We gave him atropine. He got better. Gave him chloride. Got better. Glucagon. Started with insulin and the PICU, maintained for 30 hours, and he went home in 2 days. So bradycardia is hypoxemia until proven otherwise, but otherwise I want you to think drug ingestion because it's out there. And you know how common calcium channel and beta blockers are. Anybody here? I won't get into it. You guys are not lying to me again. Okay, focus on tachycardia. There was a scary article last year. I do a lit review for ASAP on, this is my favorite thing. Somebody looked at everybody who went home from a PGD with tachycardia to see if, like, you shouldn't send people home who are tachycardic. And it's the classic emergency department article because it said that a lot of them came back, but there was nothing wrong with them. Emergency medicine, it's a very interesting field that we're in. I mean, I've been around since the beginning. You know, the one constant in emergency medicine that we live by, and for those of you who are young, is, I'll give you an example. How many of you would rather die than do psych? I'd like to die twice. I call a psych consult. I work in an academic center. I get a psych resident comes down, and I am thrilled that they're going to take over the case. I am happy that they did that. Do I disrespect them for doing psych? No. I'm happy. I don't know what they do in there, but it's fine. I don't care. No, I mean that in the commonest terms. Emergency medicine, however, is the only subspecialty in the world where someone who has no clue of what you do assumes that either you're doing it wrong or they can do it better. Now, what's that? Who's nodding? Okay, so that's my burnout message for the day. But what? So we publish literature that is I got to get a better word that's in my head, self-aggrandizing, in the sense that how many tests can we stop doing? How many, we're always looking to minimize, you've seen the phrase, test minimizer, test maximizers. You got to be between the two here, people. I have residents who are minimizers. Any residents here? I'm sorry, Mike had said, do we have any residents? Oh, there's a whole set of jokes I didn't roll out. My residents are trying by the third year to be scientific, and they said, well, I don't see the validity in getting a calcium on this kid. I said, shut up and get it. Yeah, my residents are annoying. Are there any med students here? Oh, can I have another 20 minutes? But all kidding aside, this article on tachycardia, I don't know why I got into that, was not helpful. I mean, how many of you have had kids where everything is better? The kid is dealing cards and telling jokes. Let's say a dry kid that you've given 40 per kilo to, Zofran, he's drinking, he's fine, and the nurse says his heart rate's still at 108. What do you do? Well, this stupid article will scare you, but the article is poorly written and not acceptable. I'm going to show you the tachycardia that matters. All right, here's another algorithm, the overview, and you could probably teach me more about tachycardia from adults than I see with kids, okay? We're going to talk about pathologic tachycardia, and let's start with this one. A 2-week full-term infant comes in sweaty and short of breath for 3 hours. That's it, 2-week-old. Breastfed, agitated on exam, he's a little sweaty, and you take the vitals and heart rate's 240. And the nurse is on the monitor, and his respiratory rate is 50, his blood pressure is stable, and he's actually stable with that rate, is 240. You talk about the power of pediatrics. Here's the cardiogram. I wish the ones on the boards were this easy and easy to read. Take a look, okay? And he's in SVT. I'm not out to trick you. And it's the most common dysrhythmia we see in kids and babies. There are some pathologic reasons for it, WPW and other alternative pathways. That's not the point of this lecture. Your job is to decide what to do about it, okay? The EKG features of SVT are listed. Widened QRS is a telltale sign that you better be thinking of something else. The teaching point I want to put here is on the next slide. I have brilliant peds cards people in Syracuse, and their cut line for SVT in babies under 2 is 220. If it's over 220, it's always SVT in their mind. Bottom line, unless the kid's a meth head or something. You get my drift. Okay? So 220 is a big one. And you know how to tell the difference with sinus tach versus SVT. I'm not going to hit you hard on that one. Here's an algorithm you can't read. It's from Up to Date, but I love doing that. But the acute therapy is you shock the people who are shocking. You all know this. Shock kids. I've never had to do this in SVT in kids, but it's there. Leading to vagal stimuli, the diving reflex. How many of you have done the ice to the face? Not personally. One person? Okay. Well, let me see. I think I put a picture in. Okay. I Googled this clip art from this guy. This kills me. This, by the way, when you look this up, this machine, it's only $2,200. I was very impressed with that. It was 3 in the morning. Here's the ice bag, and here's the I have no idea what the hell that is. All right, let me get to the point. I've done this a million times. It will work. It's amazing, but you have to do it right. You do not take 2 gloves, fill them with ice, and give the kid a cool compress. You take a big-ass bag, a plastic bag of ice, you turn around to the parents, and you probably should get them out of the room. Why don't you want parents in a room? Performance anxiety. Is that a fair statement? It's like making love with a porn star in the room to critique you. Come on, that was a complex joke. But my point is, get them out, or the staying, you're going to say, on that clock, 15 seconds, I am going to asphyxiate your baby. I am going to put this ice on the face, and it will work. Which leads me to the real world, which is adenosine. How many of you have given adenosine to any mammal? Okay, thank you. I don't have to qualify it. You know more than I do about it. You can double it, give it near the heart, yada, yada. And 12-lead cardiogram is very important. Peds guys are great. If you get the transitional cardiogram between the SVT, the pause, and then the regenerative rhythm, they can actually see the regeneration and tell you where the aberrant pathway is. Very cool. The coolest thing I've ever seen with adenosine is I had a senior resident, and we called the cardiologist. We had an SVT stable kid. We got the room lights down. We gave the kid a little morphine. The baby's sucking on a nipple. The child life person's in the room. The art therapist was eating. And I'm visualizing. And we gave the adenosine, and the heart rate dropped. There was the pause, and sinus ensued. And my resident goes, great. And the kid goes into a Moreau and goes back into SVT. And I thought it was amazing. I love that stuff. All right. Didge, God, what the hell came out of my mouth? Didge. Yeah, it works. It's the second-line drug for this in peds. You'll never have to do that. You'll stick with adenosine. And then I'm on time. My summary. Number 1, read the new guidelines. It'll take you 7 minutes. It really is CAB. Atropine is gone, epinephrine never leaves, and hypoxemia is the most common bradycardia cause. I am going to see you tomorrow. We're going to do scary babies and people who can't breathe, babies who can't breathe. And with that, I will see you soon. Thank you.
Thanks so much, Rich. I'm going to grab the lavalier. So
What do you need?
clean Michael.
Yeah, okay.
And just while we're switching over to our last talk for today, recall